don't mind putting your name and your organization and which city or municipality you are hailing from, that would be fantastic. So hi everybody, Andy Dwyer, University of Colorado Cancer Center, Colorado School of Public Health, and the CCSP program. And we're delighted to have folks joining today. I think we had 35 registrants, and I know some of the folks weren't able to attend real time. We're just getting people on right now. So your name, your organization, and what city or town that you are joining us from, that would be super fantastic. So everybody, I'm super excited that we have Dr. Wani and his team joining from the GI team, part of the University of Colorado and the University of Colorado Cancer Center joining us today. As many of you know, much of the work here at the university does really actually reflect a lot of the programs, a lot of the services that are being delivered clinically and from the research community. So the CCSP program focusing on lower GI work is something that we've really focused with many of you in the field and many of our program partners throughout the state and the country. But as you know, we through CCSP have worked on lung cancer screening, really looking at genetic hereditary work, and then really continuing to think about what sort of services, opportunities, and partnerships might really prevail in terms of our work in thinking about the prevention, early detection, and treatment of cancers. And so I have had the honor of really working with Dr. Wani and his team as they've reached out, really interested in making more community connections outside of the Cancer Center and within all of Colorado to really think about how do we partner to share more information about esophageal cancer, the services and resources, and I think a lot of the great expertise and work that's happening at our Cancer Center. So thank you everyone so much for really joining in today. I'll have Elsa share a little bit about the logistics and the flow. And then we know that we have Dr. Wani and his team really joining in terms of really talking about what are we talking about when we mean esophageal cancer, some of the latest trends, but also some great resources. So I'm just super excited because I have to tell you, it's always such a bright spot when many of the investigators and researchers from the Cancer Center see the value of CCSP, see the value of so much of the great work. And I have to tell you, this team has been super excited about working with us and thinking about partnerships moving forward. So if you're just joining the party, your name, your organization, and what town you're hailing from would be super fantastic. So Brooke Miller, you did a beautiful job. I just saw your information pop up. So go ahead and add that in. And then also I'll have you help introduce part of the team as well. And then we will have Dr. Wani present for us today. So Elsa.
Thanks so much, Andy, and thanks everyone for joining. I'm Elsa Staples. I'm the Senior Program Manager for CCSP. And so as Dr. Wani goes through his presentation, please feel free to put questions in the chat, comments, discussion points, and at the end, we'll have a chance to review all of the questions, go through all of those, and also probably opportunity for folks to come off mute as well if they want to expand on their question or go into a bit more discussion, as we definitely want to make this an interactive webinar today. And really exciting to see such a variety of folks on today from many of our CCSP clinics all across the state, on the western slope, down in the San Luis Valley, Eastern Plains, and other partners. So if you're new to CCSP, we'll be posting the slides and the recording from today's webinar on our CCSP website and sending out that link. So you can also share with others who are not able to join today. And then lastly, I did want to mention there is closed captioning available on your bottom toolbar as well. If you'd like to show those captions, you have the option to click on that option as well. But without further ado, I'm going to turn it over to Dr. Sechin Wani, who's the chair at the new Rady Center of Excellence at the University of Colorado Cancer Center. So thanks so much, Dr. Wani.
Well, thank you so much, Elsa, for that kind introduction. And thank you, Andy. It's just been an absolute joy working with your team. And I'm sure we're going to achieve some of the milestones that we've set as a part of our Rady Center of Excellence. I really have one basic goal, which is to really raise awareness for Barrett's and for esophageal cancer and save as many lives as we can and change the epidemiology of this lethal cancer. And hopefully at the end of this presentation, you're going to start thinking a little bit more about what you can do as an individual to change these trends and reduce the morbidity and mortality associated with esophageal cancer. So I'm just going to give you an update on where we are primarily on screening for Barrett's and for esophageal cancer, which will be preceded by sharing some information on the epidemiology of Barrett's and esophageal cancer. Talk to you a little bit about what we do in our clinical practice when we make a diagnosis of Barrett's esophagus, highlight some of the strategies that we employ in our practice to manage patients with Barrett's, and especially when they start progressing towards esophageal cancer, what we can do to avoid them reaching to this point of invasive cancer where we know the overall outcome is not so great. And as a framework for this discussion, I'll obviously use an evidence-based approach. I'll highlight some of the guidelines that have been published, what are the quality indicators that we use to guide practice, and also highlight some of the ongoing research that we are doing here at the Rady Center in collaboration with multiple centers all over the country. And we have some international ongoing collaborations as well. And of course, talk to you a little bit about our newly established Rady Center of Excellence. I say newly established, but it's been about a year and a half or so since we first inaugurated our center. So let's get started with a few basics. I know not everyone may be familiar with some of the terms that I may be using, so I just wanted to start off with a few basics. What you're seeing is an endoscopic image in a patient who was referred with chronic reflux disease. And on the left, you can see that the lining of the lower portion of the esophagus has changed. It no longer looks whitish, like you can see right at the top of the image. It looks pink or salmon colored. And this is what Barrett's esophagus looks like. It's a precancerous condition for esophageal adenocarcinoma, and we make this diagnosis of Barrett's when we take biopsies during our endoscopy, which demonstrate these bluish colored cells, or what we call as intestinal metaplasia, characterized by goblet cells. So we need to have a combination of these two factors to make a diagnosis of Barrett's esophagus. I will tell you that Barrett's esophagus is highly underdiagnosed. It's remarkably common. It's seen in about 7% of all individuals who have chronic reflux disease. So take a second to pause to think about how many patients you see or encounter in your practice with chronic reflux disease. It's believed that up to 5% of the adult US population may have this precancerous condition called Barrett's esophagus. And the reason why we care about this condition is that it's the only identifiable premalignant condition for this nasty looking cancer, esophageal adenocarcinoma. Here's a patient who did not get appropriately screened for esophageal cancer and presented with late stage esophageal adenocarcinoma. And we know that the overall survival for patients when they do get diagnosed with late stage disease is dismal. I wanted to shed some light on what we've seen over the past 4 to 5 decades as it relates to the epidemiology of esophageal cancer. The graphs on the left demonstrate that the incidence has been rising at a fairly rapid rate over the past 4 decades. And you can see the breakdown in these different age categories. But the theme is consistent in almost all age categories, except for age less than 50. You're seeing an increasing incidence of esophageal cancer. I think the graphs on the right are far more telling, and you can appreciate the incidence of esophageal cancer as it compares to other commonly encountered cancers in clinical practice. Look at the incidence of esophageal cancer compared to the incidence of, say, breast cancer, prostate cancer, lung cancer. So obviously, this is something that we've been seeing a lot of in our clinical practice, and this definitely convinces us that we should be paying attention to these epidemiologic trends. Again, this is a slide to just highlight the fact that when you look at the 5-year survival rate for all comers, all patients diagnosed with esophageal cancer, the 5-year survival rate is 20%. And think about how many cancers that you see in your practice actually have such a dismal 5-year survival rate. But what is reassuring is the fact that 5-year survival rates are really dependent on the stage at which you make the diagnosis of esophageal cancer. By that, I mean, if you make a diagnosis of cancer at stage 1 disease, their 5-year survival rate can be as high as greater than 90%. So this all provides the necessary face validity for us to identify the precancerous condition, which allows us to detect esophageal cancer at an early stage. What is gratifying to see is that all the efforts that we've made over the last few years have resulted in some improvement in the incidence rates. There is data, and the graph on the left shows that you're now seeing that the incidence rate of esophageal cancer may not be rising as rapidly, and that may be related to some of the screening and surveillance strategies that we've been working on. But what is still disappointing is that if you look at the stage at which esophageal cancer gets diagnosed, the vast majority of cancer diagnosis is still made with the advanced stage or with metastatic stage disease. So that's the paradigm that we're going to change, hopefully, with our Rady Center and with all the work that we're doing at the present time. I wanted to share some of the epidemiologic trends that we've seen in the state of Colorado. And you can see that our incidence rate, which is about 4 per 100,000 individuals, is really not that different from the US age-adjusted incidence rate, which is about 4.5. This is a really nice graph that actually tells us areas where we may need to focus a little bit more than what we are at the present time. This tells us where the incidence of esophageal cancer is the highest in all the different counties in the state of Colorado. Now, when you look at the trends in terms of the incidence rate, we've seen actually an improvement in the incidence rate over time. And this actually shows us the age-adjusted rate for the cause of death related to esophageal cancer, which appears to be declining as seen in that graph. Here are some of the rates for the age-adjusted mortality rate within the state of Colorado and how it compares to the surrounding states. And this is a heat map demonstrating what the mortality looks like from esophageal cancer in our different counties. And this has given us some framework in terms of how we want to proceed in terms of raising awareness, spreading the word for screening and surveillance for Barrett's esophagus, focusing on these counties to actually implement some of these screening programs that we're going to talk about. So here's a graphical representation on how Barrett's can progress, right? And I have another slide to highlight that. But again, just as a reminder, it starts off with chronic reflux disease. That's one of the prerequisites. Whether the patients experience reflux symptoms or not is not a prerequisite. We know that reflux results in a change in lining of the esophagus, causes damage to the lower esophagus, results in a change in the lining where a diagnosis of Barrett's is made. And in a small subset of patients, you're going to see progression from Barrett's to invasive esophageal cancer. So what can we do so that we can detect esophageal cancer at an early stage? I'll talk to you a little bit about what our guidelines recommend as it relates to screening. And if you focus your attention on the column right in the center, these are the most recent guidelines that have been published by the American College of Gastroenterology. And these guidelines suggest that individuals who have chronic reflux disease, these are individuals who've had reflux symptoms and may be on a PPI and have had resolution of reflux symptoms. They're still considered as individuals who have chronic reflux. And if they have 3 or additional risk factors: males, age greater than 50, Caucasian race, central adiposity, history of smoking, and a family history of Barrett's esophageal cancer. That is, 1 to 2 first-degree relatives with Barrett's or esophageal cancer should fall into your equation to decide if an individual should be screened for Barrett's or esophageal cancer. So this is your target population that you need to consider screening for. Now, while it makes intuitive sense that these are the individuals that you should be screening, and we've got some observational data showing that when individuals get screened, you detect Barrett's, you detect esophageal cancer at an early stage, and these individuals have improved outcomes. I will tell you that overall, we've not done as well as we would like to in terms of screening individuals who are at risk. And let's talk about some of the barriers that we face. Think about the individuals that you see in your practice with chronic reflux disease, right? So subjecting them or referring them to a gastroenterologist to do, or anyone who does endoscopy to screen for Barrett's, obviously puts an enormous burden to our medical resources. We know that Barrett's esophagus can be completely asymptomatic. I can't tell you how many times I've encountered patients that I've seen in my practice with Barrett's with high-grade dysplasia or early cancer that tell me that they've never experienced reflux symptoms. But probably the statistic that's the most disturbing to me is the fact that less than 10% of patients that we see in our practice with esophageal cancer have undergone an endoscopy in the past or have had a prior diagnosis of Barrett's esophagus. So a really small fraction of patients actually get screened appropriately and get diagnosed with Barrett. So this really just suggests that our current paradigm of screening fails to detect patients who are at the highest risk. And this is despite the fact that we perform more than 2 million upper endoscopies in the United States for the diagnosis of reflux disease. Now, when you think about how many individuals, what's the denominator of individuals who are at risk for Barrett's or esophageal cancer and should undergo some sort of testing for Barrett's, it just depends on the guideline that you are looking at. And that denominator can range from 20 million individuals to as high as 120 million individuals. A logical question at this point is, well, we know what the denominator is. How often are patients who are truly at risk for Barrett's or esophageal cancer getting screened appropriately and being referred to a gastroenterologist for an upper endoscopy? And these are some examples of large observational studies suggesting, again, similar to that statistic that I talked about earlier, about 10% in one study is the number of individuals who actually underwent an upper endoscopy for screening for Barrett's esophagus. Yes, we made a diagnosis of Barrett's esophagus in another 20% of individuals, but these were all individuals who were referred for an upper endoscopy because they had other symptoms such as trouble swallowing, abdominal pain, GI bleeding. So the true population that underwent a screening exam is actually much smaller than we would like. And at this point, when you think about the barriers that our physicians, our healthcare providers face, by and large, the biggest issue is having the resources available for patients to undergo that upper endoscopy testing, lack of knowledge of guidelines, difficulty in identifying at-risk individuals, and a lot of providers do report that they just don't have enough time to think about esophageal cancer screening. And that, I think, is not the right strategy, because I think we owe it to our patients who are at risk to ensure that we screen them, identify Barrett's, and identify esophageal cancer at an early stage. This study that we did has given us some benchmarking data and led to some intervention trials where, and this is one intervention that we're focusing on, which is raising awareness, ensuring that folks understand when they should be screened for Barrett's and for esophageal cancer. So our goal here at the Rady Center and the University of Colorado is to change the status quo. And I'll start off again with another example, which is unfortunately far too common in our clinical practice. This is a patient that I saw a few months ago, a 52-year-old Caucasian male with chronic reflux disease, symptoms that were well controlled on PPI therapy and well plugged into our medical system. He kept up with all his appointments to appropriately manage his hypertension, dyslipidemia. He was diagnosed with early diabetes. He had a prior history of smoking, but at the recommendation of his primary care physician, stopped smoking as well, but ultimately presented with symptoms of dysphagia. And when I did an endoscopy, as you can appreciate, he's got a large mass that's consistent with invasive esophageal cancer. What was worse was I did an endoscopic ultrasound on him, which allows us, by the way, to stage the cancer, which is something that we do routinely in our practice when we stage patients with esophageal cancer. You can see the image on your bottom right where I've marked a lesion in the left lobe of the liver. This was consistent with metastatic esophageal cancer, so stage 4 disease. You know, his 5-year survival is absolutely dismal, less than a year. So this is exactly what we see in our practice, and this is what we are trying to change. One approach that we can all use in our clinical practice is to really think outside the box and start thinking about non-endoscopic screening strategies that allow us to collect cells from the lower esophagus, cells that get tested for biomarkers that are associated with Barrett's esophagus and esophageal adenocarcinoma. And these are some of the devices that are either under investigation or approved and ready to be used in clinical practice. And I'll spend a little more time talking about the device all the way to the right, which uses a balloon-based system to collect cells from the lower esophagus. The systems to the left use a sponge, which basically is collapsed within a capsule. It gets down to the stomach in the presence of acid. This gets deployed into the sponge, which then collects cells from the lower esophagus. These are all devices that can be administered outside of endoscopy labs in clinics by primary care physicians, physician extenders, nurses. So this really is a paradigm shift in the way we could potentially screen for Barrett's and esophageal cancer. If you really care about the data, we have data from several observational studies showing that the diagnostic characteristics are fairly good as it relates to these cell collection devices. These are data from the balloon-based system that I was talking about earlier, EsoCheck and EsoGuard, and you can appreciate that the overall sensitivity, of course, the sensitivity is better with longer segments for all cell collection devices, but with this device, the overall sensitivity was about 90% and specificity greater than 92%. And subsequent to this study, there have been multiple other reports again demonstrating that the diagnostic characteristics are excellent for screening individuals for Barrett's and for esophageal cancer. This is the only randomized control trial which was conducted in the UK that used a sponge-based system, again demonstrating that when you use this non-endoscopic cell collection strategy, you're going to detect more patients with Barrett's esophagus. This trial was not powered for detection of Barrett's-related neoplasia or cancer, but this study actually showed numerically a higher number of patients diagnosed with Barrett's-related neoplasia as well. So based on all of these data that I presented and more, our most recent guidelines that we published 2 years ago, this non-endoscopic screening strategy has now been approved by our guidelines as an acceptable alternative to endoscopy to screen individuals who are at risk for Barrett's and for esophageal cancer. So this was a landmark recommendation made by our GI societies, again, with the intent of improving our rates of screening for Barrett's and for esophageal cancer. That's Jasmine. She's one of our research coordinators. And that was me when we swallowed one of these cell collection devices. So it's fairly acceptable by all patients, and several studies have consistently demonstrated that this is acceptable to patients compared to endoscopy. I have a video that I'd like to show at the end, but just to go over the steps when it comes to collection of cells using these devices. We use, here's just one example. This is using the EsoCheck system. It starts off by patients swallowing this capsule, and you can see the size is actually smaller than your daily vitamin tablet. Patients swallow this capsule. It goes down into the stomach. We inflate this balloon. It collects cells from the lower esophagus, and then we bring the balloon back into this capsule so that you don't lose the cells and you don't contaminate your sample with squamous epithelium in the proximal esophagus, and then we send it for analysis. We actually conducted this test on a patient yesterday, and I am not kidding. It literally took us 2 minutes to complete the complete administration of this device. And of course, you add another 5 to 10 minutes to put it in the preservative and then sending it off for analysis to a central lab. So it can be done fairly quickly. These are some of the markers that we use to guide how far this balloon has gone. And this is just an example of how this compares to some of the other cell collection devices that we use in clinical practice. An example that you can compare EsoGuard to is PAP testing for cervical cancer. We have the option of either having these clinics in our primary care clinics, in our GI offices, and that is something that we are incorporating here at the University of Colorado, where we will have clinics for screening in our GI offices and amongst clinics that are conducted by our primary care physicians. There are other testing sites available as well. I can envision a time where we conduct a camp where patients all that are at risk for Barrett's and esophageal cancer come and get tested. But these are all things that we are working on actively as a part of our Center of Excellence. Just recognize that this is covered by patient insurances as well. Just so that you know, patients get a report, and of course the providers as well. And it's a binary result. Either you're positive, and if you're positive, then you need to be referred to a gastroenterologist to confirm the diagnosis of Barrett's esophagus and ensure that patients don't have any dysplasia. So they get biopsies done during that endoscopy. If they're negative, they can either be told that they no longer need to be screened, or if their risk profile changes, you could consider screening again in the future. And it's very similar to this concept of Cologuard testing for colonoscopy as well. I wanted to share an example, again, a real life patient that we took care of, a veteran who underwent testing using these non-endoscopic cell collection devices. I've actually told this patient to thank his primary care physician because that test actually saved his life. He went to his primary care physician. He got tested by the cell collection device, EsoCheck, that turned out to be positive. He was referred to a gastroenterologist who took samples, confirmed the diagnosis of Barrett's with high-grade dysplasia, and then was referred to me for further management. And this is what his endoscopy showed. Hopefully, I'm not going to ruin your appetite. I see it's about lunchtime, or you may be eating lunch right now. But this is what the lower part of the esophagus looks like. You can see the squamous epithelium, but that pink-colored mucosa is what Barrett's esophagus looks like. And here I'm using advanced imaging techniques that we routinely use in our clinical practice, which allows us to predict the histology, and it also allows us to guide our endoscopic eradication therapy. I've got a distal attachment cap that really allows me to inspect the area very carefully. And right off the bat, I'm sure you can appreciate this area in the 3 o'clock position just does not seem right. It looks lumpy or bumpy. And this is what I think the referring gastroenterologist biopsied and sent this patient to us. Once we realized that we had this finding, we proceeded with what we do routinely for these patients, which is to remove these lesions. I'm using a technique called endoscopic mucosal resection, which is basically sucking that lesion into a cap. I deploy a band, and then I use a snare, which is like a lasso, goes over this lesion, and then I go ahead and use heat to get rid of anything that looks suspicious or abnormal within the patient's Barrett's esophagus. So I'm sure you are curious to know what the overall diagnosis was for this patient. This patient was actually diagnosed with superficial esophageal cancer. You can see the endoscopic image. We got rid of the cancer completely during this endoscopic procedure. The patient then came back for a follow-up exam. We did some touch-up treatment using radiofrequency ablation, and is now free and cured of his esophageal cancer. And here's an histologic image demonstrating intramucosal cancer. This, I think, is the paradigm that we are aspiring for. This is what we hope to do in the future for all patients who are at risk for Barrett's and for esophageal cancer. While this is where we are at the present time, this is what we're going to do for screening. Now, imagine a time where you could actually have a test that you can actually swallow, and take this test at home without having to come to a clinic to test for Barrett's and esophageal cancer. And this is what we're looking at. Not ready for prime time, but this is work that we're doing actively here at the University of Colorado. Imagine if you could swallow just the string that stays in your esophagus for an hour, and then the string then gets analyzed for biomarkers. You take the string out, you put it in a preservative, and again, you get results that tell us whether you've got Barrett's esophagus or not. And at least based on our preliminary analysis, it looks like the string can pick up on all biomarkers that are traditionally associated with Barrett's esophagus and esophageal cancer. So we are in the pilot trial phase here at the university. So stay tuned. We'll have more results on this home-based test for Barrett's and for esophageal cancer. Our group is actively involved in research that really cares about a patient approach, a patient-centered strategy for screening patients with Barrett's esophagus. And this is a study that we are embarking on in these next few weeks that will allow us to assess from our patients, what do they prefer? Do they prefer to undergo the string test? Do they prefer to undergo the balloon-based system, or the traditional endoscopy or transnasal endoscopy? This is all work that was already done in the past for colorectal cancer screening. So we're really just following the same pathway for esophageal cancer like the experts in colorectal cancer have in the past. We're also not too far from a point where we can actually enter all patient-related data into electronic medical records, and your EHR will tell you if your patient is at risk for Barrett's or for esophageal cancer, and will give you a best practice advice statement or within your health maintenance tab that your patient is at risk for Barrett's and esophageal cancer. Consider screening this patient for esophageal cancer. So this is also work that we are leading here at the University of Colorado. So stay tuned for some of those efforts as well. So just to close the discussion on screening per se, hopefully I've convinced you of the following. One is we're not screening individuals appropriately for Barrett's and for esophageal cancer. If our goal is to really have an impact on the burden of esophageal cancer, unfortunately, wrong patients are being referred for an endoscopy. Reflux disease is not so great as we thought as a screening criterion. So we obviously need to start thinking outside the box. What if you had a patient who is a Caucasian male, age greater than 50, and with a history of smoking, but really does not report any reflux symptoms? This patient meets all the other risk factor profile for Barrett's and for esophageal cancer. We should be thinking outside the box and consider screening for those individuals. We are now at that stage where we are collecting effectiveness data for screening, especially using these non-endoscopic screening devices. The future really lies in all of us really collaborating. This mission that we have for changing the epidemiology of esophageal cancer cannot be achieved in a vacuum, cannot be achieved by gastroenterologists alone. This requires collaboration with our primary care physicians. And of course, when patients do get diagnosed with Barrett's-related neoplasia or cancer, we need a multidisciplinary strategy for management of these patients. In these last few minutes, I just want to talk to you a little bit about some of the work that we're doing as it relates to surveillance. It's important to note that not all patients with Barrett's esophagus will actually progress to esophageal cancer, and that progression happens in a stepwise manner. So when you do have a diagnosis of Barrett's, we take biopsies to determine if they have dysplasia, which then determines the next step in management. these are some of the data as it relates to the natural history in terms of progression of Barrett's esophagus. The progression rate is fairly small. It's about 0.25% per year. Recognize that the vast majority of patients with Barrett's esophagus will not get esophageal cancer and are more likely to die of cardiovascular diseases and other cancers. This is what we do as endoscopists when we have patients with Barrett's esophagus. We take biopsies. We also brush the Barrett's esophagus, and we then send these biopsies to our pathologist to tell us, is it just Barrett's, or has the patient started progressing towards esophageal cancer? And when we do a high quality examination of the Barrett's segment, this is what we're trying to do, which is to identify if our patients have any areas that harbor early cancer or high-grade dysplasia, so that these patients can then undergo endoscopic eradication therapy. Our goal is to avoid having these patients undergo esophagectomy, which obviously has its own set of risks and complications. I will tell you, the work that we're doing here at the University of Colorado is really focused on not just doing a high quality exam, but improving our yield of detection of Barrett's related neoplasia and cancer. So in addition to taking biopsies, data have suggested that when you do this brushing, you're more likely to detect Barrett's-related dysplasia. What we don't know is, can brushings actually replace these 4-quadrant biopsies that we take? And that's the focus of a large multi-center randomized control trial that we're conducting through the Rady Center and within our GI division across 14 other sites here in the United States to answer this fundamental question. So this is what our research protocol looks like, where patients get randomized to forceps or Watt sampling, and then the order is reversed so that patients get sampling using both techniques. And what we care about is ultimately detection of Barrett's-related neoplasia. But this will also set the stage for multiple other research projects that we're working on in the future. Lastly, I will just spend a couple of minutes talking about where we stand as it relates to these endoscopic therapies. Why are patients being referred to us when they get diagnosed with Barrett's-related high-grade dysplasia or intramucosal cancer? I will tell you that until about 2005 or 2006, if you ever had a patient with Barrett's with high-grade dysplasia or intramucosal cancer, these patients were actually being referred for an esophagectomy. So we've come a long ways since then. These patients can easily be managed with our endoscopic tools. And this strategy has now been endorsed by our GI societies. And what we really care about is eradicating all Barrett's esophagus. And of course, our long-term goal is to reduce cancer-related mortality. This cartoon just gives you some idea of who are appropriate candidates for endoscopic therapy. So for patients who get diagnosed with high-grade dysplasia or intramucosal cancer, as long as the lesion is above this brown layer of muscularis mucosa, these are all appropriate candidates for therapy. On the other hand, if you have a lesion that breaks through that brown layer in this image, or the muscularis mucosa, these are patients who have submucosal cancer, and they should at least be evaluated in our multidisciplinary clinic to determine appropriate management, because these patients are at risk for lymph node metastases. Our guidelines now recommend that these patients should not be referred for surgery and should undergo endoscopic eradication therapy. If you have high-grade dysplasia, these patients should undergo endoscopic eradication therapy over surveillance. And for low-grade dysplasia, we use a patient-centered strategy. There's some some obvious knowledge gaps on how to manage patients with low-grade dysplasia, and we have a large multi-center randomized controlled trial that is assessing how patients with low-grade dysplasia should be managed. Should they undergo ablation or should they undergo endoscopic eradication therapy? We're extremely fortunate that this is being funded by the National Institute of Health and NIDDK, and we hope to have the results of this trial hopefully in the next 5 years. This trial and the Rady Center and our group, everything that we're doing has really galvanized a lot of research support from the NIH. It's got this entire group of investigators together to conduct pivotal research in our field. So if you have a patient with Barrett's, please consider referring these patients to our center for further evaluation. And I suspect these patients will be enrolled in some of our research trials. We've also been able to convince the NCI to fund some of our research focusing on biomarkers. Imagine a time if you could actually predict which patient with Barrett's is actually going to progress to esophageal cancer. That would be a beautiful moment for our patients with Barrett's, where they can be treated way earlier in their paradigm, or be told that you never have to worry about your Barrett's because you're never going to progress to esophageal cancer. And lastly, I just wanted to spend some time to share with you some of the work that we've done through our Center of Excellence. As I said, this center was inaugurated about a year and a half ago, largely due to this massive philanthropic gift that we received from Katy and Paul Rady, and we're so grateful for their generosity and for them to share our vision on really changing lives for patients with esophageal cancer. I want to acknowledge these wonderful individuals who do such amazing work day in and day out. Kelly DeLay, who is the medical director for our benign clinic, Megan Marsh, who runs our esophageal and gastric multidisciplinary clinic, Daisha, who's just joined our center and will be the director of innovation and translational research, and of course Jessica and Maddie, who do such amazing work day in and day out for our center. Our goal really is to establish the center as one of the top esophageal and gastric centers in the country, and these are the different pillars that we focus on through our center, focusing on the highest level of clinical care that we can provide to our patients with esophageal and gastric disorders, conduct quality, cutting-edge research. We focus on education, screening, patient advocacy, and I encourage you to go to our website, where we have a lot of information there about the ongoing studies that we're doing, how you can refer a patient to our esophageal and gastric multidisciplinary clinic. Here's a picture of the group when we first inaugurated our benign multidisciplinary disease. I want you to be aware that our center focuses not just on the precancerous and cancerous disorders, but also on complex foregut disorders, motility disorders. So again, a huge shout out to Megan, who's fourth from the left, who really leads a lot of these efforts, and incredibly grateful for all her hard work. And then lastly, this is just some information on our research interest group that meets on a monthly basis. We talk about our ongoing research, the next grant that we're planning to apply for, and this has really led to a lot of cross collaboration across several divisions and departments within our institution. And again, a shout out to Daisha, who's just recently joined our group. We care about patient advocacy deeply. We work with ECAN, which is at least one patient advocacy group that cares about Barrett's and esophageal cancer, and we hope to expand some of these initiatives. And a shout out to Lauren and Colin, who've really helped lead some of these patient advocacy and survivorship missions within our center. And then, of course, acknowledgement to our research team. Several of them are on this call today, and all these amazing investigators that I get to work with day in and day out. This trial in itself includes 27 centers participating in the SERVANT trial here in the United States, and these are the centers participating in the SWOT-BE study. So with that, here's our information. I've got Megan's information if you have a patient to refer to our multidisciplinary clinic. Information to contact Maddie, and our website has information on how to reach out to me if you have any questions or suggestions on how we can collaborate. Thank you so much for your attention.
Thanks so much, Dr. Wani, for that very informative presentation. I definitely learned a lot about both Barrett's esophagus and esophageal cancer. We have about 8 minutes for questions, so I'd encourage you all, if you have questions or comments for Dr. Wani, to go ahead and put them in the Q&A or the chat. It looks like we have one question in there to start us off with, which is someone asked if I have a patient that is a 50-year-old male who has a history of tobacco usage and GERD, what is the first step I should take as a provider?
Yeah, fantastic question. You've just described a classic patient who's at risk for Barrett's and for esophageal cancer. So the first thing you need to do is refer that patient to a gastroenterologist to get screened for Barrett's and esophageal cancer. As and when we collaborate and we have a system in place where you can refer this patient for non-endoscopic screening tests, the paradigm will be that patient will undergo that test in your clinic. And then if that is positive, that patient will then be referred to a gastroenterologist for an upper endoscopy. Until that happens, please refer this patient to a gastroenterologist to be screened for Barrett's esophagus. And that will happen through an upper endoscopy. And if you have difficulty in getting this patient scheduled, please reach out to us and we can certainly be of assistance.
Dr. Mani, team, and I have to tell you, I think this is super exciting because I really love also the map that you showed of the state, right? And looking at what the incidence and the data is telling us. And I know as a program that works with a lot of community clinics that are FQHCs, rural health centers, critical access hospitals, we're exploring like what are these opportunities with particularly the Rady Center funding and those opportunities. But I think as we're starting to see folks who are in the rural communities and who are FQHCs, who have patients who need services at the U, or we're really thinking about like services out into the community. You know, I know we've had some talks about planning that way. But if folks are really looking for some immediate opportunities for partnership, I heard you say making referrals to the U, right? Even connecting with you and the team, that's one thing we can do. But, you know, I think the thing I was interested too, as you were talking about, like really looking at maybe some of the areas in the state where we start screening programs or really start to think a little bit about these sort of partnerships. So I guess what is your vision with the resources that we have at the U right now, in addition to the referrals coming to the university, but what do you think we can do in terms of some of the reach in with the clinic systems and partners who might be on today?
Yeah, fantastic question, Andy. You know, we're really in the infancy stage, right, where we're actually rolling out these non-endoscopic screening strategies. Our intent is not to have every patient who is at risk for Barrett's and esophageal cancer to get an endoscopy here at the Anschutz Medical Campus. Our goal is to just first ensure that they're talking to their primary care provider, and then the primary care provider identifies that individual to be at risk and refers that patient to a gastroenterologist to get screened, right? Obviously, the UC Health System has several satellite hospitals with GI services, so those patients could be referred there. And these patients then ultimately just need to come to the main campus only when they get diagnosed with Barrett's related high-grade dysplasia, low-grade dysplasia, or cancer. So that's the vision. And will this, and I think one of the key steps that we need to take as a program is to ensure that if a patient does undergo this test and is positive, do we have a system in place for that patient to get that follow-up endoscopy, right? It's pointless to get diagnosed as someone who has a positive EsoCheck and EsoGuard, but cannot undergo an upper endoscopy to confirm that they have Barrett. So to ensure that we have that system in place, that our GI systems can actually accommodate all these upper endoscopies, this is all issues, welcome issues that we should be prepared to address. We're not there yet, but I would love to be, and I know Kelly's on the call as well, we'd love to be in a situation where all these patients are coming in for an endoscopy. These are all patients who have positive EsoChecks, and that we perform screening endoscopies, not necessarily just at Anschutz, but within our UC Health System or any other gastroenterologist.
Mm-hmm. Perfect. And I did notice that Cheyenne out in Uncompahgre, actually almost to the Utah border, and that team was talking a little bit about Dr. Prince and making sure these materials come this way. I think everyone, as part of the CCSP team and the work with Dr. Wani and his team, you know, these are things that we're going to continue to have ongoing discussion. And I think that if there's opportunity for travel, getting in front of folks around some of these opportunities. I know clinical schedules can be difficult, but I think even some regional meetings and things coming forward, we could definitely find some dedicated time for CMOs, as well as many of our healthcare teams and directors to continue this conversation. So I think this idea really in the program and with the community, and I think as you said, Dr. Wani, is that it's in the infamy, but or in the early component of this, and really thinking about these partnerships. But there's going to be hopefully a lot of opportunity to continue this discussion. So excited about really many of you who joined today. And I know there were about 10 to 15 more that wanted slides later to really think about that linkage in the community, and super excited about that. So so Cheyenne, thanks for that note, and we'll definitely make sure that your CMOs and team get all of the connection for today. Also, do we have
final quick
more
question I had for Dr. Wani is for primary care clinic systems, both in rural areas and on the Front Range as well, are there tools right now, like decision aids or other tools that can help primary care clinics with identifying patients that are at high risk for Barrett's esophagus and should be screened?
Yeah, our team would be happy to share some of these resources and clinical decision tools that have been published by our GI society. So we'd be happy to share that as a follow-up, not just a slide deck, but also some of these clinical decision tools that have been published. Happy to do that.
Great. Yeah, if you want to share those, I could include those in the follow-up email as well.
Yeah, Maddie, Jessica, and I will work on this, and we'll share that with everyone.
Thank you so much, Dr. Wani.
It's my pleasure.
I think we're about at time. So Andy, any final closing thoughts before we close for today?
No, I just think that we're really excited about the potential and opportunity. I mean, CCSP, again, is a network we definitely utilize to disseminate best practices, evidence, tools, and resources. And I just want to say a huge thanks to the GI team here for joining in and really thinking about the art of the possible, because I mean, that's really how many of the ideas have blossomed, and we're really excited about future and next steps and getting number of direct messages and emails about how to really think about partnerships moving ahead. So thanks, everyone. And Dr. Wani, thanks so much for the time, and everyone for the dedication. So have a good one. Thanks, guys.
Thank you so
Thank you,
much. It was my
everyone.
pleasure. Bye-bye.
Bye-bye.
Have a great afternoon.